Hello, 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 everyone. Thank you all so much for attending this presentation. I look forward to engaging with you all through the duration of this presentation and talk about a topic that is near and dear to my heart, to what I do professionally. So I hope that at the end of this presentation, you will have learned something that you feel inspired to take back with you to your professional life, your personal life, and just continue to advance this message that we will discuss today. We will be talking about medical gaslighting and gatekeeping and how it is antithetical to improving health literacy and outcomes. I am Terry McGuire. I am a practicing physician assistant with a public health background. I have over a decade of experience. I'm also a health literacy consultant and the founder and CEO of Evolve Health and Wellness Community, where we support both patients and healthcare organizations to improve personal and organizational health literacy, respectively. So we'll go ahead and get started. All right. So as we advance through this presentation, we will discuss definitions. We'll talk about implications of medical gaslighting as well as gatekeeping. We'll delve into some case studies. We'll discuss solutions, and then we'll summarize what we discussed during this presentation. And then, of course, there will be an opportunity for you to reach out once you're completed to ask me any questions. So let's try to move this out of your way. So let's talk generally. What is gaslighting? So, gaslighting is actually a form of psychological abuse, and it basically is an exploitation of a power dynamic. So, someone or a group of people who have more power. They take advantage and they use manipulation to incite self doubt within someone else. And over time, this can essentially lead someone to start to question their feelings, minimize their judgment, or even sometimes challenge their own sanity. So there's actually a movie called Gaslight that was released in the 1940s, and it depicted this phenomenon. So between a husband and a wife, and it basically just showcased a series of manipulative acts that led the wife to feel that she was really um, kind of just questioning what she was experiencing. And basically, there was the emergence of gaslighting in psychological literature in the 1960s and pretty much focused primarily on domestic situations and just talking about how gaslighting can eventually lead to intimate partner violence. And so, if you have personal experiences with um, domestic abuse, you may know that it has a subtle presentation. It is not direct, it's not always obvious to begin with. And so a lot of times it can be missed, and people do not always understand what is actually happening as they are going through it or as they're being manipulated. Let's try to advance. Ooh, my goodness, I advanced too much. Okay. Alrighty. And so when we are talking about medical gaslighting, so talking about gaslighting within a medical context, this is basically when we see anyone in the medical community, so it may not be a healthcare provider, but someone in the medical community who has power and dismisses a patient's symptoms, undermines, and basically says that their symptoms that they're experiencing are minor, they do not exist, or they're just simply in their head. This can often be linked a lot of times to dismissing concerns for women as a result of the misogynist stereotype that has transcended time, that women are not rational beings and they tend to lean towards hysteria. And just to give you some background on this, Hippocrates, who is also known as the father of medicine, basically held the belief that the womb traveled through the body and caused an excessive emotional response. So it caused women to be hysterical, or people with the uterus to be hysterical. And this actually was in the DSM, so this manual that outlines a number of mental health disorders until the 1980s. This term was not removed from the DSM-3 until the 1980s. And obviously, hysteria could also be a term to describe men or non-binary people, but again, it was used as a diagnosis until the 1980s. So again, that's not that long ago. And also just delving a little bit more deeply into this term, people who tend to lack power, whether it's socially, whether it's economically, cultural, they don't have social capital, they tend to be the targets of medical gaslighting most often. Black people, people of color, people who are older, people who live with disabilities, people who are gender nonconforming tend to be targets of medical gaslighting, people who are typically pushed to the margins of society and have a marginalized identity definitely can relate more to being on the other side of medical gaslighting, unfortunately. So, as we're continuing this discussion, as I briefly alluded to earlier, it's that this behavior can sometimes be very subtle, and within a medical context, it can sometimes masquerade as optimal care or expertise. So, thinking of a healthcare provider and a patient being in a room together, it's most of the time it's one-on-one, unless you have a support person there, and it's a private setting. And a lot of times people already enter the setting intimidated. And so there's this power dynamic that you have to navigate. And so if you come into this setting and you feel very confident about something that you're feeling or experiencing in your body, and someone tells you that they don't believe you or they minimize, then sometimes you can challenge even what you're feeling and say, oh, well, I'm not the expert in this situation. This person, this provider knows better than I do. They're trained and they just want to care for me. So again, it can be very subtle and it may not be directly obvious that this is happening to you as it is occurring. This often leads to patients feeling powerless or incompetent. And so as a physician assistant, I see a lot of patients, and most of the time, if my patients, as they are experiencing symptoms, they've already done their research. Now, whether or not they're researching reputable sources or not, they come in and they have an idea of what's going on with their bodies. And, sometimes the conversation has to be streamlined, but it's very important to listen because they are the expert. Patients are the expert of their own body. And so making sure that we are not shutting them down as they are communicating things that they are feeling, things that they have noticed, things that have changed. Some examples of medical gaslighting, some phrases can look like or sound like, oh, you don't look like you're in that much pain. So pain is subjective. So of course we can ask patients on a scale of 1 to 10, how bad does it hurt? Is it with 10 being more severe? Everyone does not physically show pain in the same way, the severity of their pain rather. And so to look to see how someone is looking or make a decision based on how they present outwardly is a form of gaslighting. So telling someone they don't look like they're in that much pain because there is research that shows that people can be undertreated for pain. Again, and that comes through a form of gaslighting. Or another term, you're too young for this condition. Again, as patients research, they come in with ideas of what may be happening or what they are experiencing. And so it is very important to not cut off patients, make sure that you're listening to them and understanding that there are outliers in everything. There is nothing that is impossible in medicine, even though it may be a rarity, it's not impossible. So again, just making sure that we're listening and not cutting a patient short or cutting diagnoses out of the picture just because of a patient's age. Or you're just constipated. So again, sometimes patients can present in a clinical setting with a specific symptom. And sometimes, as medical providers, we may treat that symptom. But again, if a patient continues to present and things are not changing with interventions that have been recommended, then definitely do a little bit more digging to understand what could that constipation be related to. There are a number of conditions, and some of them can be very serious that cause constipation. So to just say that a patient is just constipated, then it can make them feel like, what am I doing wrong? I'm implementing all of these recommendations and nothing is changing, when in actuality, there is a serious diagnosis that needs to be addressed. And then lastly, I've been doing this for years, trust me. So, yes, medical providers are trained. There is a lot of schooling that takes place, but there has to be shared decision making in clinical settings. And again, making sure that there is not this power dynamic that's happening and patients don't feel like they're being talked at, but they're actually a part of that conversation and they're being engaged in their care and they're being believed. So, moving on, we'll talk about medical gatekeeping. So, this basically is exactly what the term implies. So, gatekeeping, someone with power is keeping the gate. They are controlling what is going out of that gate and what is coming into that gate. In a medical context, this typically occurs when healthcare institutions, organizations, or providers are placing restrictions on care, making it harder to access care or causing unnecessary delays. Oftentimes, there's this rationale that medical gatekeeping is done to lower healthcare expenditures and account for shortage of healthcare specialists. And while that is true, it is only partly true. And if you think of it, if a medical condition is undiagnosed, to lower healthcare expenditures. So there is a gate place and maybe imaging is not ordered or the medication is not ordered and a serious diagnosis is missed, then the money that is thought to be being saved, in actuality, it will not be saved trying to figure out at the end what is actually going on with that patient. And if it is a serious diagnosis, how do you actually treat the condition that was missed? So again, this can relate to specialists. So controlling when a patient can see a specialist. So a lot of times you may see this with HMO insurance plans or as a primary care provider saying you don't think that a patient needs to see a specialist, you can manage it, okay? Or you don't think they need a particular image. Or a lot of times insurance companies, if a provider orders a specific image, they'll say, no, this costs too much money. We're not going to pay for this until these measures are met first. Medications, there can be gatekeeping with medications. One being PrEP. A medication to prevent HIV transmission. So there is data, there are studies that shows that there are disparities in who is actually prescribed this medication, gender affirming medication. There have been roadblocks placed to prevent people who need gender affirming care being able to actually receive that medication to help them be able to exist in a body that feels best and right for them. Although there can be gatekeeping around resources, so determining who is actually going to have a resource and who is not. And then lastly, education is another form of medical gatekeeping. So there was a study done that looked at a number of really popular medical journals And they wanted to look to see how often racism was actually discussed in this journal, because racism, we know, is a public health emergency. It certainly impacts health outcomes. There's no diagnostic code for it. We can't quantify how much racism impacts health, but we know that it does. Yet, and still, these really popular medical journals, there were a lot of discrepancies about how often they actually named racism as a cause for a number of health conditions. So that's gatekeeping to censor journals from actually releasing information. So it's essentially not naming the problem and then also not allowing the medical community to be able to read this data, to be able to understand how they can change their practice. And then also, I want to speak to, again, just a little bit more in depth about lowering healthcare expenditure. So the UK uses a system with a lot of gatekeeping, but there's also reports that they also underdiagnose different types of cancers, so colorectal cancer, breast cancer. So again, if you misdiagnose a cancer, you're actually not saving a lot of money in the long term because treatment is very, very expensive. And so I don't want to get too off topic, but there are a number of other ways to control costs within our healthcare system and to advocate for better expenditure, because it is a problem in our healthcare system. In the end, in the United States, we do spend more money than other countries, and our healthcare outcomes do not reflect that. So we definitely do need to make changes in how we spend money, but it does not have to come at the expense of a patient and being not being believed or missing a diagnosis, or really, again, just exploiting that power dynamic. So, continuing further, when we're talking about medical gatekeeping, so there are three different types of gatekeeping that we will discuss. So, traditional, so that is basically practicing rational medicine. So, as a healthcare provider, we do have a duty to do right by patients and try to not only help patients, but to help the overall public's health in general. And so, we do have to utilize our training and be mindful of that. And some examples of traditional and rational medicine is antibiotic stewardship. So if a patient's lab work or if their presentation is not consistent with a bacterial infection, then it's not reasonable to prescribe antibiotics, because that can have an unwanted side effects for the patient, whether it's GI upset or it can actually lead to antibiotic resistance that can sometimes be fatal. Also, just being mindful of how pain medications or other narcotics are being prescribed. So we know that we have a problem with opioid use and overdoses. And so we do want to be mindful in making sure that we are saving lives and we are not over prescribing medications that are not necessary. And we'll talk a little bit more about bias and just working through these things and just making sure that our decisions are rational, but also not being impacted by our biases. There is a negative form of gatekeeping. So this is basically employing limitations to control costs. So what we were just reviewing, so insurance companies denying a prior authorization for a particular image because they're saying that they're not willing to pay for it, or refusing to approve a brand name medication. So brand name and generic medications, they're very similar in terms of their formulation, but there can be very small differences that can impact patients differently. Some patients are very sensitive, and so their bodies can recognize if they are not taking a brand name medication. And then lastly, there's positive gatekeeping, when a service is actually being pushed towards a patient for personal gain. So that means recommending a specific medication because of financial incentive from drug companies. And so it's not uncommon that healthcare providers are paid when they prescribe a certain medication. This is a form of gatekeeping, again, because you're controlling what you're going to give to a patient, which may not necessarily optimize their healthcare. So if there are a number of other medications that you're not considering because you're fixated on the particular medication that is um, allowing you to make money from it, then that is gatekeeping and that is not acceptable. So this conversation is very, very important. And as I alluded to earlier, so this all matters because as healthcare providers are making decisions about patient care, it's really, really important to consider not only explicit bias, but also implicit bias. So explicit bias is going to be the obvious beliefs, attitudes, and feelings that are held by healthcare providers that influence how healthcare is delivered to patients. So that can be a healthcare provider saying, I am not comfortable directing this patient to get abortion care because I don't personally believe in abortion. And so that is a form of bias because the patient now has to suffer because of a belief system. And so definitely being mindful of that. That is obvious. On the other hand, implicit biases are not as obvious. They're very subtle, but we all have them. We all live in a world where we're influenced by our environment, where we're socialized to believe certain things. And there's actually a study where medical students, actually almost 50% of medical students said that they had heard a negative term about Black people. And by the time they had reached their fourth year of medical school, they had also internalized these feelings and they felt that they had more implicit bias than they did when they first started medical school. So clinician bias is very, very important. And we are really influenced by ideas and in our environment. And so definitely being mindful of how we are thinking when we are making these decisions about patients. Again, diagnostic errors. So when patients are undermined, when they're not listened to, when their concerns are dismissed, we're not always considering all the potential explanations, and then there can be overconfidence and in feeling like you know what's happening for a patient or what's not happening for a patient. And these contribute to errors in clinical decision making. And again, this leads to delays in diagnosis. And so we definitely want to be mindful of this. About 80% of diagnosis can be done correctly if a really good, robust history of present illness is obtained and a physical exam follows. And so, again, a good history of obtaining a good history involves really talking to a patient, really centering that patient and really understanding what's happening so that you can actually formulate a good differential diagnosis for, and that just basically means you're really considering all of the possibilities or at least the top possibilities to start of what really can be impacting this patient. And then, of course, we're here to talk about health literacy. And so, health literacy could be negatively impacted when patients are not heard, when they're not believed, when they don't know all of the channels that they need to go through or the next steps that they can take to address their medical concerns. So this places limitations on patients. Medical gaslighting and gatekeeping alike can place limitations on patients and inhibit how they navigate a very complex health system and optimize their care. So now we're going to talk about some different cases so that you can see firsthand how medical gatekeeping and gaslighting can play out in a real time, real life setting. So this is a true story. This happened. I was actually a part of um, this as a family member having to advocate for this patient. So we have a Black woman in her late 50s. She tested positive for COVID-19 in February 2021. That date is important because this is nearly a year after the World Health Organization had uh, labeled COVID-19 as a global pandemic. This woman also lives with underlying conditions, so high blood pressure, hypertension, glaucoma, prediabetes, and is clinically overweight. Hypertension is one of the conditions that the CDC has highlighted as a high risk factor for patients to develop adverse health outcomes with COVID. This patient had a virtual visit with her primary care provider, and then she had an emergency room visit for symptoms related to COVID-19. So she was not doing well. She was not um, progressing as expected. This was before vaccines were out, so there was no defense on board, and she was not offered monoclonal antibodies, which is a life-saving therapy for COVID. And it wasn't until her second visit to the ER. So again, she was not doing well. She continued to decompensate, and family had to advocate for her via FaceTime. So again, think about these early days of the pandemic. Family members could not be present in person, and so we had to utilize FaceTime. Thankfully, with my clinical background, I was able to speak to the emergency room physician and really push for her to get monoclonal antibodies. She was really getting close to the cutoff period, which was 10 days to actually introduce this medication for it to have benefit. And it really took family members who had to do education, again, research, learning about this treatment that was available, and she was not offered it. And again, even after we pushed, there was still hesitation. With the hesitation, we were asked how we knew about the medication, as if the knowledge and access should be limited to certain people. So I don't know if listening to this story, if it jumps out, if this is a case of medical gaslighting or gatekeeping. But if you chose both, you're actually right, because it's gaslighting, because it's minimizing what this patient is going through. This is someone who not only has pre-existing conditions, this is her second time presenting to the ER. Okay. And so, and then there's gatekeeping, because it was it was really a struggle to really get her this medication. So it was available, she met criteria for it, but healthcare providers were hesitant about actually allowing her to get this medication. So again, a real life situation that shows how these phenomena can actually play out. Our second case, and the next two cases were actually obtained from the New York Times. They ran a story on medical gaslighting. So we'll go through these next two cases, and so some of you may have seen them before. So case number two, Black woman who had previously been diagnosed with two congenital heart conditions. So she was born with heart conditions, but she was told she was fine. She can essentially do life without limitation. She would be able to function without any problem. But there became a point when, or she was doing fine. She was able to run 6 miles in 45 minutes, which was really great. Really good endurance, really good conditioning. But then at some point, something changed. So something from her baseline changed, and she started to experience chest pain and passing out. She knew something was wrong with her body. She traveled to see a highly recommended cardiologist who dismissed her concerns. The providers was convinced. So again, the provider made an assessment that these symptoms that the patient was experiencing were not due to her previously diagnosed condition. So there was no type of testing done. It was just a provider saying, I'm convinced. So again, thinking back to diagnostic errors, or not thinking about all of the possibilities, leads to diagnostic errors or delay in diagnosis. The physician made a medication adjustment and told the patient to rest. Patient, again, she kept pressing, sought a second opinion and imaging. Thankfully, this second provider ordered imaging that showed that arteries in her heart were not getting enough oxygen and they were spasming, which was causing her to experience that pain and the passing out. She then required open heart surgery to repair the problem. The quote she's used in the article, I constantly still think about how any run I went on quite literally could have been my last. So this is very, very, very serious. Case number three. A white woman started experiencing knee pain and swelling in the postpartum period. Before we jump into this second case, I do want to let you know that that patient was a nurse. And I don't think that should matter at all. I don't think that it should matter if someone is in the medical field or not. None of these things should matter, but it just may speak to this patient knowing something was wrong with her body, and she kept pressing. She knew that she needed to really consider other channels to get the help and attention that she needs. And every patient is not medically trained, is not in a medical setting to know, again, how to navigate that. So thankfully, she did understand that. And so now we can jump into case study number 3. A white woman started experiencing knee pain and swelling in the postpartum period. So had a baby. She told a medical provider what was happening, and they told her that the symptoms were due to postpartum depression. She saw another provider that recommended weight reduction and squats to relieve symptoms. So this is someone in the postpartum period. I don't know how far she is in the postpartum period, but if you have ever been in a postpartum period, hearing someone talk about your weight can be very hard to hear and then tell you to do squats. I don't know how she delivered her baby, but if she delivered by C-section or if she delivered vaginally, squats may not be the best thing. And again, I don't know how far she is into her postpartum period. Later, the actual diagnosis was found to be hip dysplasia, and treatment involved surgical repair. Her quote, "It took 3 years to get a diagnosis and another 2 to heal." So, diagnostic error, the time that it takes. So, again, if we're thinking about reducing costs and we're thinking about how the multiple visits that these patients have to go through, these are costs. And then thinking about all of the time it's taking to actually get a diagnosis, this is accumulating costs over time. So the idea that negative gatekeeping can control costs sometimes is smoke and mirrors. Our last study is a case that happened not long ago. A middle-aged Black woman and physician was hospitalized for COVID-19 after testing positive on November the 29th, 2020. She also lived with sarcoidosis, which is an underlying inflammatory condition that commonly impacts the lungs. She documented her treatment while she was hospitalized, and she discussed having to beg for remdesivir. So remdesivir is another antiviral treatment that can be given to inpatients. And she talked about being denied adequate pain control. So again, going back to the subjectivity of pain and how people are not always believed when they say they are in pain. One of the quotes that she said, "He, or the physician, made me feel like a drug addict." So as she's hospitalized, she's in a lot of pain, and the exchanges that she had were very negative, and she was not given pain control right away, and she was made to feel that she was seeking pain medication. She shared during the time that she was documenting her stay that there was discussions about discharge, and she felt it was a bit premature. She did not feel well. Another quote, "This is how Black people get killed, when you send them home and they don't know how to fight for themselves." She was not feeling well. She was still released from the hospital on the 7th of December 2020. She unfortunately decompensated and was admitted to a different hospital with both bacterial and COVID-19 pneumonia. She was intubated on December the 10th, 2020, and died 2 days later after going into cardiac arrest. She was 52 years old. So definitely have some really stark cases of medical gaslighting, gatekeeping, and how this plays out. So we definitely remember Dr. Susan Moore, and I'm very it's unfortunate that we have to highlight these other stories, but they do happen. And so if we are to see change in our medical system and our healthcare system, we are going to have to name these things that are happening. We're going to have to bring light to them. So what can we do? There's so many things that can be done from a medical perspective to help turn the tide, to stop hamster wheeling, to actually see to make some actionable steps and to make change for patients. And again, improve health literacy and advance health equity should always be the goal. Some things that we can do as healthcare providers, as people who are a part of the medical community, always center patients and not another agenda. Every patient is different. So when there's a patient in front of you, really centering them, centering their story, their background, all of that plays a part in how they show up to their medical appointment, how they're going to make decisions, how they're going to manage conditions. So always centering them, listening to what they are saying. They are the experts on their body, and we can team up with them to help come to a good place to begin to determine where do we go and what steps need to be taken to come up with a diagnosis. We have to acknowledge and address medical racism. Again, this has to be named. Our healthcare system is known to be historically biased and historically racist. And when you're working within that system, those things can be internalized and those things can continue to play out until we start to name them and we actually start to address them. And again, all forms of bias. So explicit bias, implicit bias, under the umbrella of implicit bias, you have affinity bias. So having this bias that you're connecting with patients just because you can relate to them, clinician bias. So sometimes healthcare providers can write things in a medical record that can be derogatory towards patients, and a colleague can see that and internalize that messaging because they trust you as a colleague. So again, just making sure that you know what forms of bias are showing up, and definitely be honest about the fact that we all have biases. And until we're honest about that, we cannot make true change. So using neutral and objective language in verbal and written communication. So again, I was talking about making sure in the electronic medical record, or EMR, that you're not making statements about a patient that are derogatory, that are based on stereotypes. Really important. I talked about the medical students and how they felt they internalized implicit bias throughout the course of their training. This is actually called the hidden curriculum in medicine, because these are things that are learned over time that really start to become a part of how a healthcare provider practices. So utilize reputable tools to support your decision making. So again, trying not to just have a diagnosis in your head and really rely too heavily on heuristics. So heuristics is a way for healthcare providers to implement or employ shortcuts. Obviously, time is a big issue when thinking about practicing medicine, but we also want to be mindful that heuristics can certainly be distorted by cognitive bias. So making sure that you're utilizing reputable tools. If you're not sure about a diagnosis, utilize the tools that we have um, before us to help understand what may be happening, what may be going on with the patient. Also, peer review is really, really important. And peer review oftentimes works really well when you're paired with someone who does not share the same background. So, someone that can give you a different perspective when they're reviewing charts with you. Also, having a system that allows for bias reporting. So, if something is seen that is categorized as biased, then there should be channels where colleagues can feel comfortable reporting this bias, not necessarily in a punitive way. Obviously, if there is a track record, then there, may be consequences, but there should be a system to report bias so a team can address that for learning, so the team can learn and to improve practice. And also continuing medical education. So just as providers have to maintain certain hours as it relates to pharmacology, as it relates to public health, definitely having medical education that addresses these types of cases of medical gaslighting and gatekeeping, and showing how it plays out and making sure that providers are aware that they're seeing it in real time. A lot of times, um, and another way to educate patients is M&M, so morbidity and mortality rounds. So some institutions do this as a form to educate, and this is also good to highlight cases that have diagnostic error. So a lot of times it's not um, really lauded to do to discuss when error happens within a medical team, but that's where the learning happens. It should always be an environment to learn. Medicine is always changing, and so we should always be students. We should always be learning and always recognize that we can learn from our patients. Our patients are a really big puzzle piece in helping to figure out clues and put the pieces together again on what is happening in their bodies. And then lastly, decreasing load and burnout. We know that load and burnout can certainly affect cognition. And then, of course, if you're feeling tired and burnt out, it's going to make it less likely for you to really be introspective and think about ways that bias may be showing up for you and impacting care. What can patients do? Patients should always continue to trust their bodies and their instincts. I am so grateful for patients who come in to their healthcare appointments. They're well informed, they've done their research. Again, we may have to talk about if sources are not reputable because there is a lot of misinformation. Misinformation is rampant, and sometimes it can lead patients astray. And so that's where relationship comes in, and talking to patient and directing them to the appropriate resources and not gatekeeping resources that can benefit a patient. Researching reputable resources. So again, talking about those resources, not gatekeeping those resources from patients so that they can have them at their um, so they can be easily access those. Always ask questions. So I know it's hard not to feel intimidated, to really struggle with the power dynamic or not feel educated enough, but it's always good to ask questions. If you have questions, bring them in. If you have questions later, always, use your electronic medical record to ask questions and advocate for yourself. Never stop advocating for yourself. It's really, really important. As we talked about those case studies, each of those patients advocated for themselves. And it's really important to engage others. So, whether that's a family member, whether it's a neighbor, or a patient advocate for support. So, if you don't feel that you are in a position, and sometimes when you're feeling ill, you're not feeling your best, it's really hard to advocate for yourself. So making sure that you have a team of people that you can call on to help to support you as you're navigating the medical system. Also, being selective with healthcare providers when possible. Some insurance plans will limit you on who you can see, but if you do have the privilege of being selective, do your research, look at healthcare providers, look at their experience. There has been a lot of um, articles circulating recently about how, having Black providers really resonates with patients, or having a provider that looks like you, that identifies with some of your identities. And then lastly, report concerning encounters. So if you have a negative exchange with a healthcare provider that does not leave you feeling good, or something was off, definitely find the channels to report that encounter. Sometimes you can report it within the system that you're going to, within that office, within that medical system, that hospital system that you're going to. And sometimes patients report healthcare providers to the medical board. So there are definitely different channels. And so you want to make sure that you are receiving adequate care. And if it's not adequate, if it's not optimal, then certainly report that, so that again, there can be learning that can take place, and this does not keep happening to other patients. In summary, I want you to know that I really enjoyed this topic. This is my second time presenting at this health literacy conference. So grateful for the opportunity, and I really just want us to take this back again to our personal and our professional lives to help continue the conversation. So as we have seen, there are multiple accounts that highlight the disturbing and detrimental impact of medical gaslighting, and unchecked gatekeeping. So again, there is rational ways to gatekeep for the good of patients when bias is not involved, but when it's not checked and there is positive gatekeeping and negative gatekeeping, then that is problematic. We want to ensure that we are allowing patients to be able to find, understand, and utilize health information for themselves as well as others. And we want to do that all in an equitable manner. Patients and their health and wellness should never be at the mercy of preferential decisions that are not clinically sound or equitable. It's wrong, period. Lives are absolutely at stake. Health outcomes are absolutely at stake. I leave you with the question, if you are part of the medical community, what legacy will you leave? I wanted to have less of these stories, less of these case studies that I have discussed, more learning, less gatekeeping so that we can really improve health literacy, advance health equity. Thank you all so much for listening. These are my references that help me as I prepare this presentation. Again, feel free to reach out to me to ask questions. I have multiple ways to be reached. You can reach me via the website. You can reach me via my email, Instagram. I'm also on LinkedIn. I look forward to engaging with you all, continuing this conversation and continuing to do the good work that we all are doing. Take good care.